Okay, the subject which we are studying are biopharmaceutics, and which belongs to the pure pharmaceutics, in which we read some definitions of the pharmaceutics and also some areas in which how can we use the drug and how the drug will affect with us. The subject name is bio and pharmaceutics. Pharmaceutical aspects which would be dealt in the form of biological process, in which we see what is the biopharmaceutics and what are the role of the pharmacist, especially in the field of biopharmaceutics. Which are the syllabus which I already shared with all of you is, which include the definitions and terminologies, in which we will read about the definition of biopharmaceutics, its generic equivalence. We will see in detail in this subject. There are the two types of the brands. One is which are research brands, and we say these are the research brands, and these are our main areas. They have developed the APIs from active pharmaceutical ingredients, and other are our those brands which are copied, especially those pharmaceutical industries which are locally available in our Pakistan. They are making some copies, and these copies are called the generic. And we in this field we will learn if the two are more than two. Even paracetamol brand is available in our market, which are introduced by the more than 200 industries. And if we want to compare these effect of the paracetamols which are introducing by the different industries, either one is who is the top one and who is the gradually another areas, then we will have today demonstrate by taking the concept of the generic equivalence. And in other case we will see the therapeutical equivalence. In case of biopharmaceutics, we will say first pharmaceutical equivalent. I will explain you in the next classes what is the pharmaceutical equivalent is. Then bioequivalent. These bioequivalent will be converted into the therapeutical equivalent. The brands which have the same pharmaceutical ingredients, their dosage form, and also their route of administration, and also having the same therapeutic effect, we will say these are the therapeutical equivalent. In this subject we will see in the detail of the therapeutical equivalent. Bioavailability would be discussed in very much detailed process of what is the bioavailability. Actually we will say bioavailability is the amount of drug which is present in the systemic circulation or at the site of area where the therapeutic effect we should have to know. And we will divide these bioavailability in two main classes. One is our systemic bioavailability, and other is in the form of bioavailability we will say absolute and the relative bioavailability. These two types we will discuss in detail, and also we will detail how can we calculate their compositions, how can we compare brand A with the brand B, and what will the parameters which will say these brands are more bioavailable as compared to the other one. In other case, we will see the drug disposition. When we say the biopharmaceutics, we will large focus will be in the major two classes. One is pharmacodynamics and other are the pharmacokinetics. In case of pharmacokinetics, we have the major areas in which we see absorption, distribution, metabolism, excretion, and these are the areas where we have to combine these two areas. Distribution and metabolism are commonly called the disposition. We will learn in a whole chapter the process of the ADME. And the other process which we will discuss is pharmacokinetics, LADMER, which was previously in our previous level, that was ADME: absorption, distribution, metabolism, elimination, and elimination or the excretion. These are the two both terms. One is excretion and other is elimination. Elimination is a broader term and excretion is a small term. In case of when we see say about the one organ, then one organ means we are discussing about the excretion, and elimination means we are discussing from the whole body the elimination of the drug from the other areas. In this case, we will discuss these parameters in case of pharmacokinetics. Next, we will move towards the gastrointestinal absorption. In the absorption chapter, we will discuss about some theories, how the drug is absorbed in our body, what are the main parameters, what are the main things which are involved in the absorption of the drug, in which we will discuss about the physiology of the body also, and also the mechanism from where we have to start, because in case of oral route we have different pH mediums. In one is our oral cavity where the pH is alkaline, and in the other is stomach which have the acidic pH, and then the intestine which have another area of the alkaline pH. We will have to learn in all the aspects of the absorption, in which ways we see forces which are helpful in the transmembrane movement, anatomical and the physiological factors influencing the absorption of the drug, physicochemical properties of drug affecting the absorption of the different oral dosage form. In this particular area, we will also study what are the main factors which are involving in the absorption. The next chapter we will discuss about the biological half-life. In the case of half-life, we will see 3 or 4 types of the half-life. We will discuss about the elimination half-life, absorption half-life, distribution half-life. All these half-lives are the different concepts. These half-lives are directly related with the rate constant. And same way we will discuss about the rate constant, the absorption rate constant, distribution rate constant, and elimination rate constant. In the case of introduction, we will see its introduction and also its types, just I have told you the names. Then in the coming classes, we will check how can we calculate these half-lives. Particularly elimination half-life will be more useful for us, because elimination half-life is a parameter where we can divide, we can decide the number of doses or the dose interval, even the dose of the drug, by using the elimination half-life. And the other thing is determination and disapplication. Okay. Next chapter we will discuss in this subject is drug clearance. Clearance is basically that concept in which we will discuss about the volume. How much volume is cleared from the body in a unit time. The units of the clearance are very simple: ml per minute, or liter per hour, or you can say microliter per minute or per second. Because these are the 2 units, one is volume, another is the time. If we take the definition of the clearance from these units, we will say its actual volume, or a plasma, or a blood, or a systemic circulation containing any fluid which is cleared from the drug in a unit time. If I say drug clearance is 35 ml per minute, this means 35 ml is plasma getting free from the drug in a minute. If I say drug clearance is 50 liter per hour, it means I am discussing about the volume of the plasma which is 50 liter, which is clearing from the drug in an hour. We will see in so much detail, especially its kinetics and then its application, its mechanism, its model, and also determination and relationship clearance with the half-life. Then how clearance, if half-life affects the clearance. If the half-life is greater, then the clearance of the drug will be, what would be the effect of the clearance if the half-life is lesser of the drug, because there are so many drugs which have the half-life less than 1 hour, especially those antibiotics. We can say those drugs which are antibiotics have the half-life less than 1 hour and 1 to 2 hours. These half-lives are basically directly affect with the clearance, or indirectly affect with those drugs which are binding with the proteins. Next we will discuss about the pharmacokinetics. That would be the major part of our area, because biopharmaceutics would be divided into the pharmacodynamics and also the pharmacokinetics. In this subject, we will focus towards the pharmacokinetics, because pharmacodynamics you people are already studying in the your classes, pharmacology 1 and pharmacology 2. There are a lot of discussion about the pharmacodynamics. But in case of pharmacokinetics, here we will discuss what will be the fate of the drug in our body, how the drug will move in our body, what are the factors affecting on the absorption of the drug, and also the other things. As the name says, pharmacokinetics. Kinetics means movement. Pharma means drugs. Those drugs, movement of the drugs. within the body. Either it is absorbed, either it is we will give it into the directly intravascular injection, ocular injections, ocular ophthalmic preparation. Each and every route of administration will ultimately discuss about the fate of the drug, which is the movement of the drug in the body, which is pharmacokinetics. In this case, pharmacokinetics, we will discuss about its introduction, its linear and non-linear pharmacokinetics. In case of linear pharmacokinetics, we will discuss this is a smooth way. We are assuming that the drug is following some kinetic models, and also it is giving us some accurate values of the half-life. The data is so much clear. If we take the orally drugs, then these drugs are available in the less amount in the first, then they are increasing with the passage of time, and as the elimination starts, they will decrease. These are basically linear. But in case of non-linear, means we are taking the data from the drugs. These are not the linearized parameters. We will discuss it in detail. And its application pharmacokinetics in clinical studies. Next, we will move toward the bioavailability and bioequivalence studies. In case of bioavailability, we will divide it into two classes. I already told you, one is absolute bioavailability and other is relative bioavailability. This is basically comparison. Bioavailability means comparison. We have to compare. For what? We have to compare the reference. We have to compare the test with the reference. And the reference are those who belongs to the research brands. If we are making some brands which are not available which are already available in the market, but we have to show them this is same equally effective as compared as the standard is, then we will have to perform some test which will be called bioavailability or the bioequivalence. In case of bioavailability, we will check, okay, what will be the half-life of the drug, what is the elimination of the drug, what is the rate constant of the drug, what are the area under the curve of the drug, what are the different parameters of pharmacokinetic profile. But in case of bioequivalence, we have to compare with the A with B. And comparison in what sense? Comparison, we can take three different parameters. One is AUC, area under the curve, another is Cmax, maximum concentration of drug present in plasma, another is Tmax, the time at which the maximum concentration of drug present in the plasma. If we take the standard IV injection, then we will say this is absolute bioavailability. And if we take other than IV, then we will say these are the relative bioavailability. These two types will be discussed in future when we will take this chapter, bioavailability and bioequivalence, its types, its parameter, significance and study protocols, methods of assessing bioavailability. Very interesting topic, in which we will discuss about how can we check the bioavailability. The common concept is we can check the bioavailability by using only the blood or the plasma or even serum, but we can also check the data from our urine data. We can also check the bioavailability or bioequivalence studies. We can perform bioequivalence studies by taking the urine data. We will also lead some clinical point of view, in which we will discuss about the single point. Means if we check the say we are discussing about the diabetic patients, and we have one parameter, the sugar level will be reduced at this level, then we will take, okay, it's a standard value, and the same individual having the diabetic nature, but when we give it a test and also check, okay, at what concentration and what time it will reduce toward the same level of just like the standard, then we will say these are the clinical endpoint. There are 6 or 7 parameters where we can check the bioequivalence of the drug. One, A is equal to B. We will discuss in our future classes. Another case is bioequivalence studies design, components and application, report format. Okay, this is another aspect where the pharmacists can compete, especially in the field of the pharmacokinetics. Pharmacists can design a protocol. Protocol for what? If a pharmaceutical owner come to you and ask you people, I want to make some bioequivalence studies, then from where I have to start. You will say, first of all we have to make a design. Either we will work on the parallel design or the crossover design. Either it will be the Latin scale design or something else. We will make some groups. These groups should be a single blind, a double blind, and then we will take the results, and these results will be interpreted and then report to the FDA. There are two words which we will discuss in the reporting. One is NDA and other is ANDA. NDA means new drug applications and ANDA means abbreviated new drug applications. Abbreviated new drug applications are filed in the initial stages when our pharmaceutical industry wants to introduce a brand which is not available in the market and it's only extracted from the plants and even synthesized in the laboratory, and they want to make it into the market. Then they will first file a sub-application, some documents to the FDA. Which documents is called ANDA, means abbreviated new drug application. And when the FDA will give the permission, okay, go ahead, make some studies, give bioequivalence studies, bioavailability studies, and then report the other and final, and the next report will be NDA, new drug application. It means first of all we have to put ANDA and other is NDA. In the coming classes, when we discuss about the design, when we discuss about the protocols of the application filing, we will see in detail what are the parameters which we have to focus in the case of ANDA and what are the parameters which we have to report to the FDA in the form of NDA. In case of other concept which will be in the compartmental model. When we study the pharmacokinetics studies, we will divide our body into the compartments. First of all, we assume those areas where our blood is circulating, those areas where our systemic circulation is present. We will combine these all our circulatory system, our brain, heart, and also our kidneys and lungs, 5 essential organs, and also our circulatory system are called highly perfused tissues and our systemic circulation. These are called the one compartment. And other things, our other tissues, bones, and these are the other compartment. Here we will divide our subject into the segments. One segment is one compartment study. Means we are assuming that our whole body is a one compartment. And other is two compartment study. We are dividing our body into the two compartments. One compartment is systemic circulation, another is the other than areas, our tissues, our bones. We will assume the accurate concentration of drug which is present in our systemic circulation, and also the remaining drug which is present in our adipose tissues and other tissues in our peripheral tissues. This is one compartment. And two compartment is, we will have to divide it into the two main areas. One is systemic circulation, other is our body. Means in case of pharmacokinetic approach, we will only discuss if absorption and elimination. These are the basic concept of one compartment. One compartment. If we have another area in which is the absorption and elimination, means one is absorption, distribution, and elimination. This is two compartment. Only difference is distribution. If the distribution is present, then we will say it's not one compartment. And if distribution is absent, then we will say it's one compartment. In case of IV injection, absorption is also absent and only elimination. When we discuss about the IV injections having the one compartment area, we will only discuss about the elimination, means elimination half-life, elimination rate constant, elimination other areas, especially AUC and Cmax. These are all our injection sections. And but when we taking the orally something, means absorption and then elimination, we will say the drug is following the one compartment. But if there is a distribution and absorption, distribution, elimination, we will say it's not one compartment. It may be two compartment, it may be multiple compartment. The word maximum is multiple compartment. One compartment, two compartment, and multiple compartment. One means only absorption and elimination. In case of injection, only elimination. But in case of two compartment, absorption, distribution, and elimination. And these distribution are can be divided into the subdivided distribution 1, distribution 2 and distribution 3 and so on. The kinetic model will be improved. 1 compartment, 2 compartment, 3 compartment, and then ultimately we will say the word is multiple compartment. We will discuss in detail when we take this subject. Especially concept of the compartmental models, 1 compartment open model, IV injection, bolus, IV infusion. We will divide the IV injection into 2 segments. You know, IV injection have the small valve volume, maximum 5 ml. We can reconstitute antibiotics, and also the 3 ml, 2 ml and 1 ml. These are the actual volume of the IV bolus injection. But in case of IV infusions, we can say 100 ml, 500 ml, 1000 ml, 1 liter. These are the infusions which we are giving to the patient in the hospital setting. These infusions have the same kinetic profile. They can also be divided into the 1, 2 or multiple compartments. In case of IV injection, if we give some injection to the patient and IV injection, the elimination starts suddenly, then we will say this is 1 compartment. And if we give the injection to the patient and it first distribute towards our tissues, then eliminate, then we will say it's 2 compartments. And same case of infusion. If we infuse the patient IV infusion and the elimination starts, we will say there is no distribution. It means it's only 1 compartment concept. But in case of infusion which have the distribution, we will say infusion with the 2 compartment concept. We will see in so much detail, especially 2 compartment open model, IV bolus, IV infusion and oral administration. Non-compartmental approaches we will discuss those parameters which are not influencing on the compartments, especially AUC, especially T-half and clearance. In case of non-compartmental, we will discuss about the statistical movement theory, MRT, mean residence time. After taking this subject, we should be able to calculate the MRT value. MRT means the time which we can discuss, okay, what time, how much time the drug is present in the stomach, how much time the drug is present in the intestine. This is called actually MRT, mean residence time. We will calculate it by taking the AUC, area under the curve, and AUMC, area under the first movement curve. And we will AUC over AUMC is equal to MRT. We can be able to calculate the MRT after completing this subject. And other case, physiological pharmacokinetic models, in which we say PBPK, another concept, PBPK, PB pharmacophysiological based pharmacokinetic models, in which we will take each and every organ and another concept, another model. For example, liver is another compart, lungs are another compart, eyes are another compart, stomach is another compart. If we divide these organs to organs, we will say these are the PBPK approach, physiological based pharmacokinetic model. We will discuss in detail. Then these are all scenario about the single dose. We are giving single injection and then checking, okay, how much concentration present. We are taking some single infusion and checking the concentration, and we are giving some single tablet and checking the, okay, how much concentration present in our blood, in stomach, intestine. And another concept is multiple dosing. We are giving multiple injection to the patient, especially the patients who are admitted into the hospitals. They are giving more than one injections, more than one IV injection, and these IV injections can be also have the same pharmacokinetic profile. We can calculate its Cmax, okay, we can calculate its Tmax and also the AUC and different parameters, dosing interval, how much dose is needed for the patient who are giving 500 milligram per ml, or even we can adjust up by taking the complete scenario of the multiple dosing. And first of all, we will discuss these whole scenario single dose, which should be called single dose pharmacokinetics, and the other is multiple dosing regime. And in case of multiple dosing regime, we will discuss about its introduction, its principle of superposition. Superposition means if we give the one dose, then and after 8 hours we give the patient to the another dose, and how much that dose already given to the present in our body, and by adding the other dose, what will be the effect of the other dose. Then third dose, its accumulation, its fluctuation, these are all parameters we will discuss. In case of multiple dosing, we will discuss about factor, its persistent, its accumulation and loss factor, and repetitive IV injections, one compartment open model, repetitive extravascular dosing in one compartment model, and multiple dosing regime of the two compartment. Remember, same scenario, 1, 2, multiple compartment, but in case of IV injection. Okay, 1, 2 and multiple compartment, but in case of infusions. 1, 2 and multiple compartment in case of oral tablet single dose. Okay, 1, 2 and multiple compartment, multiple dosing of injections. 1, 2 and multiple compartment, multiple IV infusions. 1, 2 and multiple compartment, multiple oral tablets. These are the basic scenario where our whole syllabus is surrounding our especially the biopharmaceutics. In case of elimination of the drug, next we discuss about the elimination. Elimination, I know I already told you, elimination are the basic concept in which we check the hepatic elimination in case of liver, especially in the percent of drug metabolized, drug biotransformation reaction, phase 1 reaction, phase 2 reaction, first pass effect, hepatic clearance of proteins bound drugs and the biliary excretion of the drug, renal excretion of drug, renal clearance, tubular secretion and tubular reabsorption. We will see in the details, especially elimination of the drugs through the other organs, pulmonary excretion, salivary excretion, mammillary excretion, skin excretion and the genitalial excretion. We will divide the whole organs and then check, okay, how can we check the amount of drug which are excreted from our hairs, our skin, our eyes, our other organs. We will have a method where we will calculate. The segment will move towards our protein binding. We will discuss about the two types of the protein. One protein is present in our plasma, another protein is present in our tissues. If the drug is binding with the proteins which are present in the plasma, the volume of distribution is less. But if the drug is binded with those proteins which are present in our tissue, the volume of distribution of drug is high because it is moving from the systemic circulation to the tissues. And in case of protein binding, we will discuss about this introduction, its types, kinetics, determination, clinical significance of drug protein binding, especially in this case, in this subject of biopharmaceutics. I have made it very simple for those students who want to learn it by only taking the syllabus into the practical form. Where first of all we will read in our class, then the topic which we understand in our mind, then we will apply it in our labs, because we are making just the same practical which we are studying in our classes. Next segment, pharmacokinetic variation in disease state. There the whole scenario which we already discussed is about the healthy people, the behavior of those people who are giving the name of the volunteers. And volunteers are just like you people, the students or the other people who are healthy. But in the case of disease patient, our concept is, the case of disease, the physiology of the body is changed and the behavior of the body against the drug is also changed. And how they changed, what are the parameters which should be addressed, in the, especially when we are discussing about the kinetic profile in disease state, we will learn in these chapters. Especially determination of the pharmacokinetic variations in renal and hepatic diseases. The patient who have some problems regarding the renal and hepatics, and where we have to discuss its the dose adjustment, then we will have to check its creatinine clearance and also the dose adjustment. General approaches of dose adjustment in the renal disease and hepatic clearance. Next we will discuss about the pharmacokinetics of the intravenous infusions. I have already told you about the intravenous infusions, but we will discuss in details, one compartment, two compartment, multiple compartment, and also its behavior during the infusion, what is the pharmacokinetic profile, and when we stop the infusion, then the pharmacokinetic profile, how the pharmacokinetic profile is changing. In case of biopharmaceutical aspects of the developing dosage form, this is so much interesting when we have a new drug, new molecule, and we want to make a dosage form, especially convert into the tablet solution, capsule, syrup, eye drops. Then what are the main parameters, what are the main focuses which we have to measure with this, in this concept? We will check drug considerations, drug product considerations, what are the main areas of the drug, its product concentration, its patient consideration, manufacturing consideration, pharmacodynamic and pharmacokinetic consideration. And the last of the topic will be IV, IVC, in vitro, in vivo correlation, in which we will discuss how can we calculate by using the in vitro data, assuming that the same behavior will be in vivo. This concept is IV, IVC, in which we read its introduction, its level, basically these are 4, A, B, C and D and EC plus, and in case of it's all about the IV, IVC. This is actually our syllabus which we have to read in the subject of biopharmaceutics, and we will complete it into the during our classes. Thank you very much.